Hello everybody. Today we are going to discuss about antimicrobial stewardship. Antimicrobial stewardship is the state of intervention to measure and improve antimicrobial use in order to improve outcome, minimize resistance, and the limit cost. This has become more important now than ever before. Its utility of antimicrobial is to be preserved. And critically ill patients often need empirical treatment with high-end antibiotic in order to improve outcome. And hit hard and hit early has become a mantra in intensive care unit. Exactly how stewardship may be practiced in the circumstances depend on the involved team. So, perspective, the open ICU staff includes admitting physician or surgeon, intensivist, and the infectious disease physician. Each has slightly different priority and perspective, although the ultimate goal are the same. The admitting consultant aims to cure index patient with empiric treatment with minimum investigation procedure and the cost. The intensivist is involved with invasive monitoring procedure, mechanical ventilation, vasopressor, and renal replacement therapy. ID physician's approach is less empiric and more investigative in order to curb antibiotic use to minimize collateral damage and preserve their utility. Hence, there is tendency to explore monotherapy or narrower spectrum therapy. This differing perspective may generate tension, discord, and compromise the patient care. The ideal balance can be achieved by understanding one another's viewpoint with the intellectual flexibility in the light of the latest evidence, clinical experience, and the judgment. There is general debate about the merits and demerits of open ICU. However, this may impact antimicrobial stewardship is even more contentious because every physician is at liberty to use any antibiotic in any manner and for any patient. Now, strategy. The most effective antimicrobial stewardship strategies are formulary restriction of certain agent or class of antimicrobial, suppression of report if the isolate is thought to be colonizer or contaminant, selective or cascade reporting of organism or susceptibility, prior justification for the use of selected antimicrobial. This strategy may not work in open ICU because of the lack of acceptability to the admitting consultant. On the other hand, strategies that may work because of better acceptability to admitting consultant are discussed further. Now, rapid diagnostic to identify or exclude the pathogen. Accelerated culture-based identification, biomarker, and syndromic multiplex PCR, PNA fish, MALDI-TOF, and expert CARBA. These tests help to avoid, select, de-escalate, and terminate treatment. They need careful study before being easily acceptable in a given setting. Small local studies to identify unmet clinical need, local validation study, and true turnaround time in the field are needed. In addition, post-marketing studies of time to appropriate therapy, de-escalation, and termination of antimicrobial, length of stay, mortality, cost, and ecological impact are also required. Now about surveillance and audit, these are essential to understand the current position of the ICU in relation with others in area and else. Surveillance on continuing basis is needed to know the direction in which pattern of epidemiology and the resistance is shifting. The surveillance data presented may include only top few pathogens representing 80% of responsible pathogen. Drug susceptibility is mentioned as a percentage based on data collected. Antibiotic with at least 80% cover for most pathogens should be selected as empiric choice. Data on causative organism for particular syndrome and their susceptibility may be more important for the clinician. The steps are as follows. Identify the type of infection. For example, bloodstream, respiratory, intra-abdominal, and the urinary tract. Define the location, that is ICU or ward. Identify the patient based on the described parameter. So patient type based on the clinical risk stratification. Type 1 is low risk, meeting all below criteria. That is no contact with healthcare facility in last 90 days. No antibiotic usage in last 90 days. Type 2, that is moderate criteria, meeting more than one of the below criteria. That is contact with healthcare facility in last 90 days without invasive procedure or device, and antibiotic therapy in last 90 days. Then type 3 is high risk, meeting more than one of the below criteria. That is contact with the healthcare facility in last 90 days with invasive procedure or device, or more than or equal to two antibodies in by antibiotics in last 90 days. Referring to the empiric therapy table for the patient type, given protocol drug to start. If more than one drug option is present, the drug showing better susceptibility may be chosen. Appropriate culture before starting antibiotic therapy are always necessary. So once culture and sensitivity report is available, the presumptive antibiotic therapy may be changed. With recent increases in the level of resistance, even in the community acquired infection and in the endogenous infection, the distinction below these patient types are becoming difficult. This lead to varying choices among admitting physician, intensivist, and ID physician for empiric therapy. Education with clinical pathway and guidelines. Treatment should be based on the syndrome, guidelines, and local epidemiology. Surveillance data are needed to address this requirement. Mere documentation of resistance rate various organisms is less useful than showing which are the top pathogen producing particular syndrome and what are their susceptibilities. This will be helpful for devising empirical therapy in rational manner, which will be acceptable to all physician groups that are involved in decision making. Now, audit and bidirectional feedback. This should involve internist and surgeon rather than ID physician and microbiologist, as they need to be converted for the greatest impact of the stewardship. Focusing on ICU-acquired infections like surgical site infection, catheter-related bloodstream infection, catheter-associated urinary tract infection, Staph aureus bacteremia, candidemia as a prototype can be most useful. Similarly, studying resistant pathogens such as carbapenem resistant Enterobacteriaceae, methicillin resistant Staphylococcus aureus, and vancomycin resistant Enterococci, and the use of high-end antibiotic is likely to be most useful. Small locally done before after type studies. Point prevalence studies can be used to convince the non-believer about the improved patient outcome. Results may need to be presented in a simple, lucid format to generate interest among all physician groups. It is important to show improved patient outcome, which is a prime concern of admitting consultant, rather than promise of more elusive ecological benefit. One may draw important lesson from the story of the Semmelweis. Despite his brilliant analysis, interpretation, and implementation of infection control and hand hygiene, failure was in convincing colleague and lack of diplomatic approach. His abrasive manner led to the non-acceptance of his view during his lifetime and also to dismissal from this position. Hence, good interpersonal relationship is vital to the working of good stewardship program. Optimizing pharmacokinetic and pharmacodynamics. Prolonged and continuous infusion are recommended for beta-lactam and carbapenem. High Cmax and minimum inhibitory concentration area under curve or MIC indices are achieved by single high dose of aminoglycoside and multiple boluses of fluoroquinolones respectively. This dosing pattern needs dedicated line, loading or bolus doses, and they have problem related to intolerance, adverse reaction, volume and sodium over. The benefit of dosing as per pharmacokinetic and pharmacodynamic parameter are well recognized in the ID circle. However, they are yet to find wider acceptance among other physicians. The potential benefit of this dosing approach will be best realized in patients with high Apache score, high volume of distribution, normal or high glomerular filtration rate, and interaction with the high organism burden and minimum inhibitory concentration. Now about combination therapy. Combination antimicrobials have been used for several indications. The need for combination antimicrobial therapy for enterococcal infection has not been widely realized, while more common practice of double anti-pseudomonal cover is probably not necessary. Currently, the most frequent indication for combination is for resistant gram-negative infection. Many of the new introduced drugs, polymyxin and fosfomycin, probably need to be given in combination with other agents like carbapenem, which may not even show in vitro efficacy. The positive carbapenem effect is unlikely when MIC is 16 or more, and a limit which is in line with the UCAS breakpoint and PKPD features of carbapenem. Besides, polymyxin and fosfomycin are devoid of activity against Protease, Providencia, and Morganella. The need for using such a agent singly or in combination becomes frequent situation for differing opinion among the involved physicians. Meta-analysis concluding that monotherapy is equivalent to combination and are based on data over several decades when these are full activity of each agent. This cannot be directly exploited to the treatment of multi-drug resistance, extreme drug resistance, or pan-drug resistance infection in critically ill patients. Although colistin with carbapenem or aminoglycoside or tigecycline or fosfomycin have been associated with lower mortality in meta-analysis, the evidence is of low quality, and according to some authorities, the general message that the more the better cannot be recommended and is ecologically unwise. So, several stewardship messages have emerged from recently reported increment study, which needs to be discussed among physicians to encourage more prudent use of antimicrobial. The deleterious effect of inappropriate treatment occur after 2 days of infection, giving some point for fine tuning of antibiotic regimen. Combination therapy is associated with higher survival only if patient is seriously ill, as identified by high increment carbapenem producing enterobacteriaceae mortality score. This allows avoidance of combination therapy, which is current standard in many patients and may enable more individualized approach rather than using same multi-agent therapy for every patient in ICU. About de-escalation, initial combination of antibiotic may not have been for synergy or to prevent resistance, but because at least one drug may work. De-escalation of therapy, which is commitment to narrow down, reduces the planned duration or stop antimicrobial altogether becomes appropriate after 2 to 3 days when cultures are available. Patients who are likely to respond have done so and biomarkers have improved. Carbapenem may be de-escalated from group 2 to the group 1, cefepime, beta-lactam, beta-lactamase, or fluoroquinolone. Similar step-down approach are possible for anti-gram positive and antifungal regimen. De-escalation to the single agent, which has broad spectrum, is not in keeping with the spirit of de-escalation. The definition of wide and narrow spectrum is for clinical efficacy. Narrow spectrum agent could still interact with the pathogen or commensal to promote resistance. Hence, the only true de-escalation is the termination. This fact needs to be recognized by a whole team caring for an ICU patient. About termination of antibiotic, prolonged exposure is needed only for slowly multiplying organism on protected site, including intracranial infection and infections involving foreign bodies and biofilm. The 4 Cochrane library review shows that short course was uniformly equivalent to standard duration, including 8 days of ventilator-associated pneumonia, 7 days of pyelonephritis, 10 days of septic arthritis, and 3 days of community-acquired pneumonia. Intra-abdominal infection require typically 4 to 7 days of treatment after source control and improvement. Termination depends on nature of the infection, source control, clinical microbiologic and biomarker improvement, and on the culture of the institute. Thank you, guys.